All right. Let's see. Oh. All right. Okay, something happened to all of my virtual backgrounds. So I guess I have to stay in Yosemite forever.
That's not too bad. I think it's a decent place.
Could be worse, yeah. All right, well, this is going to be shorter than the average, so maybe we can wait a few minutes. How many people do we have? Oh my gosh, Rajiv is on. Rajiv, you're supposed to know this stuff.
The only reason I'm going to attend if you're not going to call on me.
Is what?
If you're not going to call my name and ask me to answer any questions, then only I can attend.
I thought you were giving the talk.
I wish.
All right. So how's life? How's life in Arizona?
It's great. It's good. When are you coming to Tucson? Or I thought you said something like that, right?
Yes, March.
Okay.
I can let you know.
Sure. Let me know if you go from here. We'll be happy to kind of meet and yeah.
Yeah. I have a CCHS patient who might move to the Phoenix area.
Okay.
A town called Peoria.
Peoria is a place. Yes.
I thought it was in Illinois.
It is in Illinois too. We have a Peoria too. Yes.
Okay. Well, anyway, she's not sure yet, but I told her I have a great former fellow who can handle her. Yeah.
Sure. I'll try.
You'll be great.
Thanks.
And we're always here to help. I mean, not that you need it, but
Okay. How old is she? Is she an older patient? Or?
it's a boy. Well, he's actually just about 21.
Okay.
She asked, you know, we still don't have any adult people that are taking care of these kids. So I'm following kids up to 40.
Oh, wow.
Although it's possible that Keck might be interested. Iris and I are going to talk to him next month, I think, and see if we can get him, because it's a little ridiculous. We do have a group down in San Diego that's taken on, I think, 2 of my kids. So that's good. Jeremy Orr, I don't know. He's written a lot about respiratory control and specifically about what am I blocking? Loop gain.
Okay.
He's in San Diego and he's agreed to take on some of my kids. So there are a few that we have that live down near that area. So that's working out. But
yeah, we have a challenge, but for trach vent patients, even plain trach vent patients, sending to the adult. So the same everywhere.
All right, let's begin. Everyone ready? No one's ready, except Rajiv.
I'm ready.
Let's do it.
All right, good. Okay. So the great adventure, as you know. So we're moving along. I think this is about the halfway point. So that's good. Remember, there are 2 abnormal PFT patterns. So this is in the category of pulmonary function testing, which may seem a little odd, but the reason I wanted to include this is that at least my interaction with fellows, I'm not sure they quite know what to do when they get this sort of request. So we're often asked to quote unquote clear children for surgery. So what does that mean? I mean, what are we supposed to do? All right. Well, it turns out there are some important things you can do. So we're going to talk about why do a preoperative evaluation, what the postoperative fall in pulmonary function is. Are there ways that we can predict postoperative risk preoperatively? And then once you've done that, what's the benefit of doing that? So first, why do a preoperative evaluation? So children with respiratory disease are at greater risk of developing post-operative complications, right? And in this age of sophisticated anesthesia, unsuccessful surgical outcome is less due to the operative period itself. We're not really so much worried about getting kids through surgery. That usually works out pretty well. The outcome is really determined more by how much and how long respiratory function is impaired post-operative. So the first thing is, when you see one of these kids, you need to consider how the child will look post-operatively, not how he or she looks preoperatively. Okay, is that fair? Everyone understands that? All right, so basically then what we're going to do is we're going to balance the risk versus the benefits. What is the benefit of the surgery? What are the risks of serious or lethal pulmonary complications post-operatively? There's obviously no choice in emergency surgery, but this is relevant for semi-elective or elective surgery in children with moderate to high risk from pulmonary disease. All right, so this is the group we're kind of concerned about. And the questions to be asked, or some of the questions to be asked, are, should the surgery be performed at all? I mean, I've had some situations where the surgery really didn't seem like it was going to be all that big a deal, but it potentially had high risk. And so we just said, you don't need it. Should the procedure be modified? Sometimes this is possible or helpful. What is the optimal timing and preparation? A kid, obviously, that is untreated with some sort of suppurative lung disease, you probably would want to delay that surgery, institute airway clearance, for example. And should the patient and family be warned about the possibility of postoperative problems, i.e., the need for prolonged ventilatory support? And we'll talk about that toward the end. So history and physical exam. Obviously, skillful history and physical exam are the starting points, but there are limitations. If the patient has daily symptoms from respiratory disorder, for example, she may only notice changes, even though the baseline function is important to determine. So, we've all had patients that are pretty limited, and yet you ask them how they're doing, and they say, fine. Well, when was the last time you were in the hospital? 2 weeks ago. How far can you run without stopping? 50 feet. But they're doing fine. So you need to kind of probe that. Lung disease patients may adopt a sedentary lifestyle, which may mask any true limitations that they have. Okay. Physical examination at rest may not detect abnormalities. So listen to a forced exhalation, not just quiet breathing, and ask the patient to cough, especially with neuromuscular diseases. Asking a patient to cough voluntarily should be a part of the exam of every one of those patients. You will sometimes be surprised that someone with neuromuscular disease can do, and that's the best cough they can do. All right. Well, you need to know that. If a patient has secretions, does the cough clear them? All right. Postoperative respiratory failure is not simply lung failure, it's muscle failure. All right. So search for signs of skeletal muscle weakness, especially ventilatory muscle weakness, and having them cough is one way to do that. If two patients have the same preoperative lung function, i.e. PFTs, the one with ventilatory muscle weakness will do worse postoperatively. Okay. So we just talked about this yesterday. Remember the respiratory balance. Respiratory failure is not just lungs, it also involves ventilatory muscles and central control of breathing. All right. So this is kind of a schema here. In the ideal world, if you had a patient that had some loss of physiologic function, you would like to be able to know what that loss is. That is, you would like to be able to have some sort of test or ability to, if somebody has 75% of physiologic function, that your test shows that you're down at 75%. All right, that actually doesn't happen. So if we use clinical observation, history and physical exam, the curve looks something like this. Kids can lose a lot of function before it starts to become evident. All right. So really, our clinical observation, physical exam, and history are not that sensitive to detecting problems. So if we add pulmonary function testing, we're probably a little bit better. but we're unfortunately still not anywhere near this ideal line. Okay, so that's one of the things just to keep in the back of your mind is that many patients will have lost some degree of physiologic function even though you have not detected it. Does that make sense? Everyone okay with that? All right. So again, we want to predict how the child will look post-operatively, not how he looks in the preoperative assessment. We want to know how does surgery affect our post-op lung function. We need to know that. We want to know how can we best predict how a child will do, and what can we do post-operatively to preoperatively to reduce post-operative risks. So the first question is, what is the effect of surgery on pulmonary function post-operative? Okay. So surgery is like real estate. It's location, location, location. All right. So the loss or the post-op fall in pulmonary function depends primarily on where the surgery is done. And so this is kind of the classic sorts of numbers that you see. So looking at, in this case, from these authors, vital capacity, FEV1, peak flow, and FRC. So you can see if you're doing thoracic or upper abdominal surgery, you can expect a fall in vital capacity of about 60%, a fall in FEV1 about 53%, a fall in peak flow about 75%, and a fall in FRC of about 30%. Conversely, if you're doing surgery on the extremities or face, this really isn't going to impede post-op lung function much. So the fall is probably around 8 or 9% here, 12 and very little in FRC. Okay. Lower abdominal is kind of in the middle. So 25% fall in VC, 26 in FEV1, about a 48%, that's half, fall in peak flow, and a little bit of a fall in FRC. So what the point here is, think about, the post-op course. So, if you've got surgery on the face or somebody's ankle or a finger, that person can cough, take deep breaths and so on, and that's not going to hurt them. All right. Conversely, if they have surgery in the thorax or upper abdomen, that is going to cause pain to hurt. So I'll give you a story. My father had an aortic valve replaced at age 85, believe it or not. And surgical technique is great. So he was finished with surgery about noon. By the next evening, he was eating a full dinner. I mean, he was up and had this great recovery. But my father was really stubborn. Okay. So he didn't want to take pain meds. All right. Which he didn't. Consequently, he didn't cough because it hurt. And he developed a post-op. All right. So, one of the things obvious in the post-op period to think about is controlling pain in this sort of situation so that people can take the deep breaths and the coughing that they need. This just shows things visually. I like pictures so you can see the red bars are thoracic and upper abdominal surgery. The fall in all of these parameters is much greater there. And look at for the green, which is extremity and face, there's actually relatively little fall in post-op function. Again, this is kind of the standard that people will talk about. So thoracic upper abdominal between a 50 and 75% fall in function, lower abdomen 20 to 50, base extremities 10 to 25, 25 may be a little bit high, but okay. So it's not so much what happens during surgery. It's what happens after, and it's that fall, post-op fall in lung function that gets you. All right. Just this is a case example from Allison Frey's that just shows, in this case, fall in FEV1, FEC, FEV1, FEV27, and inspiratory capacity. And that's important. We'll talk about that in a minute. And this is over 8 days in this person who had a uncomplicated pulmonary valvulotomy. So, here we are down about 40% of the pre-op value here between day 4 and 6. All right. So scoliosis. This is one that we commonly get asked to make an assessment or quote unquote clear the patient. So I just want to remind you, this is a CT scan of somebody with severe scoliosis. look at how much room there is for the lungs. All right. Compared to a normal CT scan, I mean, this is really compressed. All right. So that's what these patients are starting with. And then when we straighten them out, other things can happen in terms of kind of torque and so on that can cause problems even differently. So Nancy Ewan, who is?
Longer life.
Excellent. Okay. Did a great study. All right. She basically took a spirometer to the ICU and did spirometry on patients following scoliosis surgery every day. Okay. Up to 10 days. And this is what you found. So this is FVC. So this is percent of baseline. Okay. So this is obviously the start before surgery. And look at this at even the first to about 5 days, we're down between 20 and 40% of the pre-op value. All right, 20 and 40%. And it's pretty much sustained here. By 10 days, it's still only up to not quite 60%. All right. She also looked at FEV1, and you can see the same thing. So maybe not quite as low here, but it remains, again, low until about 10 days. Or certainly 9 days. So scoliosis surgery, which would classify as both thoracic and upper abdominal, okay, significantly decreases post-op lung function. So lung function decreases by 50% status post thoracic surgery. Now, years and years ago, rehabilitation doctors learned that if they were looking at patients with neuromuscular diseases, they would measure the vital capacity. And if someone had a vital capacity less than 15 mLs per kilo, they were in respiratory failure. They could not sustain adequate ventilation. Okay. Now here's the vital capacity. Okay. What do you think if you're post-op scoliosis surgery? Do you think you're going to be exhaling and breathing down in here? Probably not. So here we like to look at the inspiratory capacity instead. And so we would like an inspiratory capacity, and we have some data to support this, which I'll show you in a minute, of greater than 30 mLs per kilo pre-op, assuming that it's going to decrease by half post-op, that is, it'd be at 15, in order to prevent the need for prolonged post-operative ventilation. Does that make sense? Okay. So we use that as one of the parameters that we look at on pulmonary function testing with someone with neuromuscular disease or scoliosis to see what we think in terms of how well they'll be able to sustain adequate ventilation post-operative. So again, I can't emphasize too much. It's location, location, location. That's what determines the post-op course. All right, everyone okay? All right. So post-operative fall lung function is most severe when surgery is performed on chest or abdomen. It's minimal after facing extremity surgery, and the location of surgery is an important consideration. Okay, any questions about all that? Everyone got it?
But what about like dental surgery?
Well, yeah, dental surgery, in my experience, is pretty minimal. That's not going to hurt them to breathe, generally speaking.
What about like increased secretions afterwards for a little bit or something?
Well, if they have increased secretions, you can deal with that. I mean, you can do chest PT on them, for example, because they don't have an open incision down there on the chest. So dental surgery has actually been pretty benign. I actually give a talk to the dental residents every year now, which I'll let you know if any of you want to kind of chime in on or zoom in on or whatever we're doing. But I don't think that dental surgery presents much of a problem in terms of post-op lung function.
Awesome, thank you.
All right.
This is Ajay here. Can I ask one question?
Of course.
So, so most of the data from the spinal fusion surgeries that we recently discussed, those are based on like anterior spinal fusions, right? So when they actually had to enter the thoracic cage, and then when I kind of like cited some of this data to our orthopedic surgeons, they were like, we now do like posterior spinal fusion and vector rod placements where we don't enter the thoracic cage. So how, how would this change now with like the different types of newer methods of spinal fusion that they're doing, posterior spinal fusions and vector placements? Like,
Yeah, I believe that most of these were posterior, in all honesty. I should have that breakdown for you, and I don't, I apologize. But I don't think these were anterior for the most part. There might have been some in there. I mean, yes, technology is getting better, no question. And, presumably or possibly there may be less of a post-operative fall. I will tell you, off the record, I have no problem scaring anesthesiologists. By telling them this kid's at high risk. Oftentimes, they pay more attention to it and do a better job, and the kid turns out better than predicted. So improvement in technology may include that to some extent. But I think we have to start from the premise that, it's where the surgery occurs that's a problem. Now, obviously this is an oversimplification. For example, diaphragm pacer surgery, we now do thoracoscopically, okay? The post-op changes in lung function after thoracoscopic surgery, which is in the thorax, are much, much less than it used to be when we did it by an open thoracotomy. All right, so it's still in the chest, but the surgery itself is less invasive. Although Don Shaw, who basically was the one who pioneered the thoracoscopic technique for us, used to remind me, it is surgery and it's still painful. But they do better. On the other hand, I think we have seen that if we don't pay attention to airway clearance post-op in those patients, there are a number of them who do get pneumonia. So even with a lesser invasive surgery in the chest, I think there's a significant decrease in lung function.
thank you, Pete. Thank you.
Okay, everyone all right? Okay, so preoperative prediction of postoperative risk. So can we predict which children will have significant postoperative difficulties? So I turned to one of my favorite philosophers, Yogi Berra, who was a catcher for the New York Yankees, who was an amateur philosopher. And he said the problem with predicting the future is that it hasn't happened yet. And so obviously we can't predict with certainty, but let's just try and look at this. So again, scoliosis surgery, thoracic upper abdominal, predicted to decrease post-op function by greater than 50%. So there is a high risk of post-op complications due to pulmonary disease, right? And predicting post-op complications preoperatively may allow intervention to reduce these risks. That's the whole reason we do this, is can we identify risk ahead of time? And by doing that, can we reduce the risks? Does that make sense? And I'll show you an interesting study in a few minutes. So Nancy Yoon again, who is?
Long gray line.
So she asked the question, can we use pulmonary function tests to predict the need for prolonged postoperative ventilatory support? I mean, when it comes to scoliosis surgery, that really is one of the main things. Can you extubate in the operating room? Or do you have to take this kid still intubated to the ICU and ventilate them for some period of time? So she did a study looking at scoliosis surgery performed on 284 patients from 1990 to 2000. So over a 20-year period. 125 of these were able to perform PFTs, and of those, 32% required prolonged ventilatory support post-op, which was defined as greater than 3 days. And she chose that definition because 97% of adults following scoliosis surgery require less than 3 days of post-op ventilatory support. So therefore, greater than 3 days was prolonged. All right. So she first looked at diagnoses. And basically, what is shown here is if you had idiopathic scoliosis, only 7% of these patients required post-op prolonged ventilatory support. Most of them did not. Congenital scoliosis, same thing. Syndromes or tumors, kyphoscoliosis. But the thing that was significantly different was the presence of neuromuscular disease. So if you just have a diagnosis of neuromuscular disease, that gives you a significantly higher chance of requiring post-op ventilatory support than if you don't. Okay. Most patients with a diagnosis of neuromuscular disease required post-op ventilatory support. After removal of neuromuscular disease from a not multi-center, but I'm blocking this. Anyway, you know, the
Multivariate.
yeah, right. Other diagnoses were not predictive, and the p-value here you can see is nowhere near significant. So those other things didn't make a difference, but the diagnosis of neuromuscular disease did. Now, she looked at pulmonary function testing, and a number of pulmonary function parameters actually also were significantly different or potentially predictive of prolonged ventilatory support. So TLC was lower in the groups requiring prolonged support, vital capacity lower, inspiratory capacity noticed below that, magic 30. RV was not significantly different in this group, interestingly. FEV1 and MIP just not quite significantly, but we'll come back to this because in some other analyses, it does end up being a important predictor. So this shows the sensitivity and specificity of these different tests. So a TLC less than 60% predicted had a sensitivity not so great, but a good specificity. Vital capacity less than 60 had a pretty good sensitivity. Specificity not quite so bad. Inspiratory capacity less than 30 had a pretty good sensitivity also. FEV1 actually didn't. MIP less than 60 didn't quite, but neuromuscular disease again did. Now this was significant, but it looks like it was significant the wrong way. Likewise here. So scoliosis patients with the following PFTs were more likely to require prolonged post-op ventilatory support. FEV1 less than 40% predicted, VC less than 60% predicted, inspiratory capacity less than 30. And we talked about why that's the case here, because you're anticipating at least a 50% reduction post-op, and they get below that 15 mLs per kilo. TLC less than 60 and MIP less than 60 also. All right. Using multivariate logistic regression to predict the need, the most important predictors were actually age, interestingly. And I'm not quite sure why, but nevertheless. FEV1 and the presence of neuromuscular disease. All right. So these two in a multivariate logistic regression end up being the most important.
So age more than 13 years was a poor prognosis?
Was what?
Was a poor prognosis? Older
Yes.
kids did worse?
A slightly higher odds ratio. Not nearly as bad as these. It was significant, but again, not as much as these. I'm going to make an assumption that older kids, perhaps their scoliosis was more advanced.
Or do you think they were less compliant chest wall? Or do you think there's not a big difference between less than 13 or older than 13 overall?
Yeah, that's a good point. Maybe.
Mhm.
We obviously didn't measure chest wall compliance in this study. This is still Nancy's study. All right. So when predicting the need for prolonged ventilatory support in children following scoliosis, most sensitive PFT was vital capacity less than 60. Most specific was FEV1 less than 40. And the presence of neuromuscular disease was probably the strongest predictor. So in children undergoing scoliosis surgery who could not perform PFTs, all right, there were no parameters from a PSG, which predicted prolonged ventilatory support, and there were no parameters from infant PFTs that predicted prolonged support. So this is, again, from Nancy's paper. You can see that respiratory system compliance and respiratory system resistance, which you get off of infant PFTs, there really was no difference. So there are not many patients, obviously, but they're in about the same range here. PSG, baseline or nadir saturation, baseline or peak CO2, or apnea-hypopnea index, none of these were significantly different between those who required prolonged versus normal amount of post-op ventilation. So again, In those who could not do PFTs, we didn't find that doing PSGs or infant PFTs were particularly helpful one way or the other. So, pulmonary function tests are reasonable predictors of the need for prolonged ventilatory support, but they do predict for groups, not necessarily for individuals. But the presence of neuromuscular disease again remained the strongest predictor. All right, preoperative reduction and postoperative risk. So what can we do? Interesting study. Identifying a patient as high risk immediately improves the outcome. So patients identified in this particular study, patients were identified as poor risk based on PFTs and or a PCO2 of greater than 54, that is hypercapnia. And so these patients were randomized, all right? Half of the group, the treating physicians, were told that their patients were high risk or poor risk. In the other half, they were not told. Interesting study, okay? Look at the mortality. For those in whom the physicians were not told their patients had a poor risk, 60% mortality. 60%. Compared, now these are high-risk patients, obviously. Compared to when physicians were told, they were able to intervene and reduce the risk to a 22% mortality. All right. So identifying a patient as high risk immediately improves the outcome. So when treating physicians are told that a patient has high risk, they can do a number of things. In adults, these are adult studies, they could stop cigarette smoking, they could give antibiotics if appropriate, they could give bronchodilators if appropriate, they could start chest physiotherapy, or perhaps modify or delay the surgical procedure. Okay? So the most important facet of preoperative evaluation is the modification of risk through appropriate preparation. So the benchmark should be correct everything that is reversible, and then prepare the patient for the remaining problems. Even chronic disorders have a reversible component. All right. So one of the things you want to do is be sure that when you're seeing patients that their therapy is maximized and appropriate for what they're doing. If they've got suppurative lung disease, they should be on airway clearance. If they've got asthma, you certainly want them on controllers and bronchodilators, etc. All right. So for patients identified as high risk for prolonged ventilatory support, you inform the surgeon and the anesthesiologist, and you also inform the patient and the family. So this prepares the patient waking up with an ET tube in place that this was expected and not due to some unexpected catastrophe. All right. So when I've identified, again, commonly scoliosis patients, as someone who I think might be at prolonged risk, I talk to both the child and the parents and tell them this is likely to happen and what that looks like. All right. So that hopefully they'll remember that discussion when they wake up in this. All right. So things we want to do, lung disease obviously should be stable. We don't want recent exacerbations. Now, as a general rule, there should be no acute viral respiratory infection within 4 weeks. I want to stop on this for a second because we're having a lot of problems here with children with some of our CF patients. So some of our CF patients, for example, need a porticap or perhaps need some other not major procedure. Anesthesia is insisting that we wait at least 4 to 6 weeks since their hospitalization. What I'm trying to convince them is that for most of these patients, their lung disease is better than it will ever be right after the hospitalization. So there are some potential exceptions to this sort of rule. I have to say we haven't completely convinced our anesthesiologists about this yet, but this for someone that doesn't have something like CF is a good general rule. Obviously not acute, no acute bronchospasm in asthmatics, and adequate O2 and CO2. So these are things that you want to do to try and reduce the postoperative risk. Any questions? Everything okay? All right. So just to summarize, children with respiratory disease are at greater risk of developing postoperative complications. Unsuccessful surgical outcome is less due to the operative period. It's determined more by how much and how long respiratory function is impaired postoperatively. You need to consider how the child will look postoperatively, not how he or she looks preoperatively when you see them. surgery and general anesthesia decrease lung function postoperatively. Postoperative fall is most severe when surgery is performed in the chest or abdomen, least severe on the face and the extremity, and the location of surgery is an important consideration. Identifying the patient as high risk immediately improves outcome, and when treating physicians are aware of a patient with poor risk, they can reduce the risk by doing several things. Adults stopping cigarette smoking, giving antibiotics, pump failure, chest therapy, etc. History and physical and PFTs help predict postoperative risk. Whoop, typo there, sorry. The most important facet of preoperative evaluation is modification of risk through appropriate preparation. And again, correct everything that's reversible and prepare the patient for the remaining thoughts. Even chronic disorders have a reversible component. Okay, so next time, which I guess is going to be probably what, January 3rd? Let's go to calendar. I'm off for the next 2 weeks. So yeah, I think it should be January 3rd. Is that right, Tim?
Yep, January 3rd, just confirmed it. Yep, you got it.
Okay. So January 3rd, we will return to the Great Adventure. And this is kind of historical interest, and we're going to talk about some tests that you have not done, but you should be aware of them. Okay. So tests of small airway disease, we'll talk about why these were developed and go over some of them and just so you're aware of them. And you might at some point in time find that you want to use some of these in some of your studies. Okay. Any questions?
Tom, that was great as always. And I did have one question, looking at Nancy's study, both the vital capacity and the FEV1 were predictors, low numbers were predictors for worse outcome. Are the two connected in that I didn't see if she had looked at the FEV1, the ratio itself? Because it's counterintuitive in severe restrictive lung disease, the two would be decreased.
Right. Yeah. Excellent point. You love that ratio, don't you? I don't, since I didn't include on the slides, I actually don't remember it. I'm surprised that she didn't look at it, but I'd have to go back and look at the paper to be honest with you. I don't remember. It's a good comment. Any other thoughts?
So I'm wondering, did we check? So I'm comparing this with PEC test to some degree. So we, always we thought PEC test doesn't cause a problem. Then we started doing some exercise studies, and now we find that it's more cardiac impairment of the stroke volume versus the more of restrictive lung disease, which caused them to have problems. So I've never now, as you showed that CT, I'm wondering, should we order echoes on these kids too? Because maybe that must be adding to a lot of the post-operative issues too.
That's an excellent point. In our place, usually the orthopedists consult cardiology as well as us. So for whatever reason, they get into cardiology faster than they get to us. So we usually have an echo, which obviously if it's a problem, then cardiologists are going to handle that primarily. But most of the kids that I recall, they're okay.
They're okay.
And Rajiv, if I may add to that,
Sure.
usually in the scoliosis patients, it usually has to be very severe, and it's more in the adolescents that we see this impairment of stroke volume. Whereas in the pectus, we see it in a lot younger age groups with the severe pectus.
Yeah, I think you're right, Dominic, on that. Yeah.
And especially.
So I'm old enough that I remember when people were afraid to do scoliosis surgery on people with severe scoliosis, and that was really a dismal time because we basically just watched them die. And they died from not only progressive respiratory failure, but they also developed progressive heart failure and pulmonary hypertension.
Mm-hmm. And the second related question I have is the albuterol. We usually kind of build this habit of giving albuterol before and after. And I'm not sure if there's any evidence of that. Even I often do that ask them to kind of start, and I'm not talking about scoliosis in particular, but most of the preoperative clearance,
Yeah.
especially if they're asthmatics, that put them on albuterol a couple of days before until
Yeah.
after.
Yeah,
what
I must
is
confess,
right,
we tend to do that also. I'm not aware of any studies.
and you don't think. The only thing I'm wondering sometime is that if they're sick a little bit or something, it might help to start. But I don't think that if patient is doing well, how much is going to help to start the
No,
albuterol.
I hear you. I think, in all honesty, I tend to do that as well. But I can't point to any studies that show that it makes a difference. It just kind of seemed like common sense, but there are a number of things in medicine that common sense turned out to be wrong. So,
And the last comment is that I might. Do you know if any studies done on idiopathic scoliosis and exercise?
I don't, but certainly, hang on, there we go. Certainly, I would expect or hope that exercise would be something more like this on this curve.
Right.
Yeah, we haven't done it. Of course, neuromuscular kids are going to have trouble getting them to exercise adequately, but like idiopathic scoliosis, you definitely could. Absolutely, good thought.
But and on the
Sorry, go ahead, Rajiv.
no, the last comment I was saying that on the same note, I was surprised that in your studies, sleep studies did not predict anything, because that is one thing we often order in these patients as a preoperative clearance.
Well, we used to do that as well. That's why she had so much data, because if they couldn't do PFTs, basically they were getting PSGs. I don't know what I can tell you except that it didn't show a difference. Now, it was not predictive for this particular problem, right, which was prolonged postoperative ventilatory support. That's not to say there might be other reasons to do it, but it didn't predict that particular problem.
Good, thank you.
Somebody, you were going to say something.
Just I had a thought, in the younger patients, especially the preschool age, will there be any role at all for lung clearance index going forward?
Excellent question. Yeah. Do you guys do lung clearance index?
I
Yeah.
wish, but
Yeah, we're kind of stuck. I had two of my research nurses who got certified at sick kids, and then one of them left. And so we're not currently doing it. We did do a couple of studies, as Ajay knows, because Ajay did them. And we haven't really been using it clinically since then. One of the problems with lung clearance index is that not many places are using it. And I think the places that are using it are not using it clinically so much. Ajay, are you using it at all?
Very, very limitedly, TK. And I think, recently we were kind of like trying to see if we can implement it on a larger scale. So we ended up like discussing with a couple of other centers. Like I contacted the guy in Stanford, Carlos Mila and Felix Madgen and Seattle Children. So none of them are actually using it clinically yet.
Oh, even Felix, right?
Measurements, and because right now there's just so much debate as to what constitutes normal reference values, what is a clinically significant difference in changes. So, and right now all studies are still comparing with like either the patient's previous baseline or healthy control.
Right.
And we kind of thought about it, but we've also figured that it's going to affect like patient flow a lot, person time and reimbursement. So we are not doing it clinically yet.
Right. Yeah, I think so. It's been used most to try and detect early disease, and that probably isn't where the money is in terms of high risk for surgery. So for this particular use, it may not be, quite as relevant as it is for other things. Now I could be wrong, but that's just my kind of initial take on it.
And finally, TK, how about like sleep apnea? Because, you know, like some of them, when they come with the snoring history and then anesthesia is like, well, like, should we do a sleep study before? And of course, you know, it's like going to increase their, delay their surgery by 3 months. So, so, you know, like since OSA could cause like potential challenges with like postoperative, like extubation, especially if they also have hypotonia or neuromuscular disease. So kind of to get by like of the challenges of not having like getting a rapid turnaround for a sleep study, sometimes you have kind of talked about similar to the neuromuscular diseases like extubating to CPAP or BiPAP and then kind of weaning support as tolerated. What are your thoughts about that? Because we often get into that challenge and then, you know, we don't want to commit to a sleep study because it's just going to delay the surgery and the patient's been waiting for months and things like that.
Well, okay, so I mean, you saw the dates on Nancy's study. It was 1990 to 2000. So we weren't as commonly extubating to BiPAP at that point in time. Now I think if the study were redone, you'd have to define prolonged ventilatory support. If you're talking about intubated, that may not be as much of an issue anymore because a lot of these kids are extubated sooner to BiPAP. Yeah, I don't know that you need a sleep study necessarily to decide that. I mean, you got a lot of monitoring in the ICU. You can kind of get an idea of what they're like.
So, but if you have a kid with neuromuscular weakness, scoliosis, don't you want to know if he's hyperventilating before you put him under anesthesia, like getting a blood gas or maybe oximetric capnography, just short of getting a sleep study?
Okay, yes, I'm not saying you shouldn't do sleep studies.
Okay.
I'm just saying they did not predict, in her study at least, the need for prolonged ventilatory support. There might be a lot of other reasons to do them, like the one you mentioned, but it didn't predict that in this group, in her group of patients.
No, I think what Ajay was, if I understood him correctly, I think he was asking, should we delay the clearance?
No, I heard that.
So would you say that it's okay to just say that it's a high risk, we can't get a sleep study, even if a neuromuscular kid who is snoring, go ahead with the surgery, but it's going to be high risk versus waiting for a couple of months and delaying the surgery? So it's kind of a hard one, but
Well, I think the answer to that is it depends what the surgery is and how badly it's needed. I mean, there's some kids that, yeah, it's semi-elective, it can wait, it won't be a big deal. There are others that you might figure it's more of a problem. Now, you obviously can get a blood gas or even electrolytes to give you an idea about chronic ventilatory support or chronic CO2 retention that doesn't take the 3 months or so waiting for a sleep study if the issue is just with the hyperventilation. And then it would depend. I mean, there's some scoliosis surgery that people plan it for the summer, several months away. So if it's that level of urgency, you can get a sleep study. If it's, no, this kid is going into heart failure, well, no, you need to do something faster. Although probably you could juggle your schedule a little bit to get an acutely ill patient in soon.
I mean, the one thing I can definitely, I'm sure that the preoperative, at least pulmonary clearance, do make a difference, because where am I now? There were some outside pulmonologists who were sending scoliosis patient directly for surgery, and they never saw us. And we have had multiple issues, including complications. So since then, our ortho people know that even if it's an outside pulmonologist patient, the patient has to be cleared by us before they go for surgery. So, and since then it is much better. So definitely that makes a difference.
Man, you are mean.
Rajiv, I was luckier that way because the orthopods I work with here are friends with David Skaggs and Vern Tolo. So I don't know, Tom, you remember David Skaggs?
Oh, yes. Yeah. He left to go to Cedars, believe it or not.
Oh, wow. And of course, the good Dr. Tolo.
I'm sorry?
Vernon Tolo.
He must have retired. I haven't seen him in quite a while.
Yeah, he has to have retired because our surgeons here, they are, those are people they look up to. So
Yeah,
Mhm.
yeah. But Skaggs, when a year and a half ago, something like that, within the last couple of years, Cedars is starting a children's hospital. It's minuscule. It's got 20 beds at this point in time, but nevertheless,
wow.
so we'll see how that unfolds. But they've actually recruited a small number of our surgeons here, and I'm sure it was money because they left like that. It was crazy. Anyway. So yeah, so the person that does most scoliosis surgery now is Lindsay Andrews, who I don't think was here when you were so many. I think she probably was when you were here, Rajiv. She's quite good, so we're still okay.
One question to the scoliosis surgery then, what do you tell patients about improvement in lung function post-surgery? Idiopathic scoliosis, they did a PFT.
Yeah,
Obviously, there are poor numbers and there is a lot of back and forth about that. And
there is, and most of the studies don't show an improvement. I'm not sure how many of those have been done with some of the newer techniques though. So I basically tell them the party line, which is it may not improve, but it will prevent it from deteriorating. And then I kind of add you might get some food, but that's I kind of don't want to go on the record for that one.
Right.
All right. There's even so many. You made it lively. Thank you. Much more.
thank you. Always like to learn from you, especially.
Well, I always like to learn from you guys too. So there.
Amen.
Thank you. Thank you.
I'll have happy holidays.
Happy holidays.
Celebrating.
Yeah, happy holidays, Tom.
We'll see
And
you
please
next
let me know, let me know the date so that I make sure I'm here, because that's our kind of a fall, spring break too for kids, so.
Yeah, it's the week of like I don't have a calendar in front of me, like the 24th or something like
Okay,
that.
that sounds good. I should be here. Yeah.
I'm not sure. I mean, so we have a student who's presenting at that conference. It's the World Congress on Spina Bifida. And she's got a nice paper, but looking over the program, the rest of it's all looks like bowel management, stuff like that, that frankly, I'm just not interested in. So when we find out when she's going to present, I think I will go for that day, but I probably won't stay for the rest of it. So
Yeah, no pressure. If you can, we can meet, then we love to meet, but I don't want you to change your programs just for that. So.
well, but I could potentially stop in Phoenix on the way either there or back.
Yeah.
All right.
Okay.
Sounds good.
Okay, sure.
But I mean, now, Somi is the one who set the high bar. When she invited me, I told her she had to take me to Graceland, which she did.
I
So,
obviously want to have you for grand rounds, but it just happened to be COVID, so.
yeah, no, I know.
By the
Yeah,
way,
I'm
that is
doing a
for
number
sure.
virtually, actually, from across the country now. So in a sense, it's nicer because you don't pay for people to come.